And continuing with the same adrenal hormones, so there's a mechanism of action. So it acts via the intracellular receptors or the nuclear receptors. Any hormones or drugs which acts via the nuclear receptors or the intracellular receptors, they have the delayed onset of action because they have to cross the plasma membrane, they have to cross the cytoplasm, and then finally enter the nucleus to show its actions. So any hormones, any drugs, any ligand, so that acts by the intracellular receptors or the nuclear receptors, so has the delayed onset of action, whereas the duration of action is longer. So the steroid hormone in the plasma, in the blood, so it enters inside the cells, inside the cytoplasm, and binds to its receptors. So it makes a hormone receptor complex, which then moves towards the nucleus, and it binds to some part of the DNA and causes the mRNA transcription and causes the cellular response like anti-inflammatory effect, immunosuppressant effect, so protein, carbohydrate metabolism, fat metabolism, etc. So this process takes at least 30 to 60 minutes. Effects of corticosteroid are not immediate, so it has the delayed onset of action. But once the appropriate proteins are synthesized, effect persists much longer than the steroid itself. So it has the delayed onset of action, whereas the duration of action is also prolonged. So what are the different types of glucocorticoids? So hydrocortisone. So hydrocortisone is the endogenous glucocorticoid, so secreted from the body, whereas the synthetic analog of this endogenous glucocorticoid is also available. So synthetic hydrocortisone is also available, and it is secreted by body as endogenous glucocorticoid, and it acts rapidly. So it is the glucocorticoid which has the most rapid onset of their action, and it is short acting. It has significant mineralocorticoid action, and it is only the glucocorticoid which has equal mineralocorticoid as well as the glucocorticoid activity. So hydrocortisone has both mineralocorticoid and glucocorticoid activity in the equal ratio, and it is available. So it is glucocorticoid secreted as an endogenous glucocorticoid, whereas it is also available as a synthetic analog, and it is available in oral preparation, intramuscular preparation, and in topical preparation. So continuing with the synthetic glucocorticoids, so the available synthetic glucocorticoids include the prednisolone, which is 4 times more potent than that of the hydrocortisone, and it is more selective glucocorticoid. So it has less mineralocorticoid activity when compared to hydrocortisone. And unlike hydrocortisone, which has rapid onset of action and short acting, so it has the intermediate action. So it is available in oral form, intramuscular form, intraarticular preparation, and topical preparation. Similarly, methylprednisolone. So it is more potent than that of the prednisolone, and it is more selective than that of the prednisolone. So it has more selective glucocorticoid activity. It has less mineralocorticoid activity when compared to prednisolone, and it is available in IV form, IM form, oral preparation. And triamcinolone is another synthetic glucocorticoid preparation, which is more potent than that of the prednisolone as well as the methylprednisolone, but it has highly selective glucocorticoid activity. So it has very less mineralocorticoid activity, and they are available in oral form, IM form, so intraarticular preparation. So continuing with the glucocorticoids, synthetic glucocorticoids, so dexamethasone and betamethasone are the most potent glucocorticoid, and they are the glucocorticoid which have only the glucocorticoid activity. They don't have mineralocorticoid activity, hence they are highly selective glucocorticoid. And they are very long acting, and they causes marked pituitary adrenal suppression. So being dexamethasone and betamethasone very potent glucocorticoids, so when this dexamethasone or betamethasone are being given, so it suppresses the endogenous release of glucocorticoid or the hydrocortisone. So dexamethasone is available in IV form, IM form, and topical preparation, and similar preparation is available with betamethasone as well. And dexamethasone and betamethasone, they are the most potent glucocorticoid, and except these two, all have some mineralocorticoid activity. So, and topically used glucocorticoid include the beclomethasone, budesonide. So, beclomethasone and budesonide are mostly used as inhalation preparation in case of bronchial asthma, whereas the topical preparation, as for example, in the form of ointment, in the form of the cream, beclomethasone are also available. So deflazacort, it is neurosteroid, it is a glucocorticoid, and glucocorticoid potency is somewhat less than that of the prednisolone. It lacks mineralocorticoid activity. It has got fewer adverse effects when compared to other glucocorticoids, which have very high tendency of causing different adverse effects, and they are being particularly recommended for pediatric patients, and it has shown lesser growth retardation if used in pediatric children. And coming to mineralocorticoids, so unlike hydrocortisone, so which was available in synthetic preparation, which is the endogenous glucocorticoid released from the body secreted by the adrenal gland. So aldosterone is a mineralocorticoid, whereas aldosterone is not available as a synthetic analog, unlike hydrocortisone, which is available as synthetic analog as well. So aldosterone is endogenous mineralocorticoid secreted from the adrenal gland as a mineralocorticoid. So it is the most potent mineralocorticoid, whereas it is not available clinically as a synthetic analog because it has the lower bioavailability and there is difficulty in regulating doses of aldosterone. And the synthetic preparation of mineralocorticoid include the fluorocortisone and desoxycortisone acetate. So fluorocortisone is a potent mineralocorticoid and is most used clinically as it has got some glucocorticoid action as well. Whereas desoxycortisone steroid, desoxycorticosterone acetate has only mineralocorticoid activity. It does not have the glucocorticoid activity. So you need to know few names of glucocorticoid as well as the mineralocorticoid. So coming to the indications, coming to the uses of these corticosteroids, both mineralocorticoid as well as the glucocorticoid. So it has got the endocrinal uses as well as the non-endocrinal uses. So endocrinal uses means when there is deficiency of producing this glucocorticoid or mineralocorticoid by the adrenal gland. So this is the endocrinal uses of glucocorticoid or mineralocorticoid or as a corticosteroid. So endocrinal uses can be acute or the chronic. So it is used as an replacement therapy in case of both acute as well as the chronic adrenal insufficiency. So acute adrenal insufficiency, in acute adrenal insufficiency, there is a sudden defective production of the steroids. There is sudden deficiency of steroid production by the adrenal gland, and it is an emergency condition, and hence the prompt therapy should be there. And risk factors of this acute adrenal insufficiency could be infection, could be dehydration, could be trauma, could be stress, could be surgery, and removal of the adrenal gland, removal of the pituitary gland, etc. And so we give the replacement therapy, and for replacement therapy, usually hydrocortisone IV or IV dexamethasone is given. So why hydrocortisone intravenous is more preferred over the other forms of glucocorticoid? Because hydrocortisone is only the corticosteroid which has got the equal mineralocorticoid as well as the glucocorticoid activity. So hydrocortisone IV is given, and in some cases dexamethasone IV is also given. So dexamethasone being the most potent glucocorticoid, so dexamethasone IV is also given. Whereas when dexamethasone is being given, so it need to ensure that sufficient water and sodium retention is there by the patient, intake is there by the patient. So both the drugs is given first as bolus injection and then the infusion. So this glucocorticoid, mineralocorticoid, or corticosteroid as a whole, so they are also used as a replacement therapy in chronic adrenal insufficiency, which is also known as Addison's disease. And chronic adrenal insufficiency mainly occurs as a result of autoimmune disease, or the reason could be some disease like tuberculosis, HIV infection, cancer, or the removal of the adrenal gland. And similar to the acute adrenal insufficiency, here also hydrocortisone, which has both the mineralocorticoid activity as well as the glucocorticoid activity, is given. Whereas in acute adrenal insufficiency, hydrocortisone is given in IV form, whereas in chronic adrenal insufficiency, hydrocortisone is given in oral form. So it should be made ensure that the patient has the adequate salt and water intake. Similarly, fluorocortisone, which is the mineralocorticoid, is added in patients who continue to excrete the excess amount of sodium. So it is also used as corticosteroid is also used as a replacement therapy in case of congenital adrenal hyperplasia. So congenital adrenal hyperplasia usually occurs when there is the hypertrophy or the hyperplasia of the adrenal gland. And why this hyperplasia or hypertrophy of adrenal gland occurs? Because in these patients there is genetic deficiency of estrogenic enzymes, which is responsible for synthesis of different corticosteroids like mineralocorticoid or glucocorticoid or the androgens. So there is deficiency of this enzyme. So the patient or the adrenal gland is not able to secrete the glucocorticoid, mineralocorticoid, or the sex hormones. And as a result, so since there is a deficiency of corticosteroid secretion, now it will stimulate pituitary to produce excess of the ACTS hormone, adrenocorticotropic hormone. So this excess amount of ACTS secretion from the pituitary gland will lead to stimulate the adrenal gland, which now will lead to hypertrophy or hyperplasia of the adrenal gland. But since there is deficiency of enzymes that is responsible for synthesis of this corticosteroid, so there will be only the hypertrophy or hyperplasia of adrenal glands. There won't be production of the corticosteroids. And synthesis of hydrocortisone and aldosterone decreases in adrenal hyperplasia. And this will lead to now compensatory increase in ACTS production from the pituitary gland, and which will lead to stimulate the adrenal gland and will cause the adrenal hypertrophy. But since there is a decrease, there is genetic deficiency of enzymes that is responsible for production of corticosteroid, there will be only the adrenal gland hypertrophy, hyperplasia. There won't be production of the corticosteroids. And so here also hydrocortisone oral is given as a treatment modality. So it has got both the mineralocorticoid as well as the glucocorticoid activity. So hydrocortisone is preferred over other corticosteroids. So coming to non-endocrinal uses, so it has the widest spectrum of medicinal uses due to their anti-inflammatory and immunosuppressive activity. And it is the drug, it is the medicine which can be given in almost all form of diseases. It is a very powerful drug. So it causes dramatic improvement in many severe diseases, as well as it produces equally dramatic adverse effect if not used properly. So use of corticosteroids should be done very cautiously. So it is a very potent drug, but it has the high chances of causing wide spectrum of adverse drug reactions. So the use of corticosteroids should be very cautious. So what are the different non-endocrine uses of these corticosteroids? So they are used in different forms of arthritis, like rheumatoid arthritis. So you have read different drugs that are used for the treatment of rheumatoid arthritis, like you have read about disease-modifying anti-rheumatoid drugs. Similarly, you have read about biological agents. Similarly, the pain is mainly suppressed by using the drugs such as NSAIDs. So corticosteroids are indicated only in severe cases adjuvant to NSAIDs when distress and disability persist despite all the measures. So obviously the other drugs like DMARDs or the biological agents need to be used but the pain that is associated, that occurs with the rheumatoid arthritis, is usually controlled by using the NSAIDs. But if NSAIDs is not able to control the pain associated with rheumatoid arthritis, or when NSAIDs are contraindicated, so only these corticosteroids are used. Similarly, osteoarthritis, which is another form of arthritis, so which affects the joint, resulting in the joint pain. So here also systemic use of corticosteroids is very rare, and in most of the cases, if the pain is there with the osteoarthritis, similar to rheumatoid arthritis, NSAIDs are used. So if NSAIDs are not able to control the pain associated with osteoarthritis, then only these corticosteroids are used. So intra-articular injection of corticosteroids should be used to control an acute exacerbation of osteoarthritis. Similarly, with the rheumatic fever, so rheumatic fever is usually treated by use of different antibiotics, and if there is increase in temperature in rheumatic fever, so use of NSAIDs is used, whereas use of these corticosteroids should be done in only severe cases if the patient is suffering from the carditis or the congestive heart failure, with the aim of rapid suppression of symptoms. Similarly, with the gout, so for the treatment of gout, there are different modalities like use of NSAIDs or colchicine to reduce the pain. Similarly, the use of different drugs like the drugs that reduces the uric acid production, similarly, which increases the uric acid excretion. So use of NSAIDs is usually done, or colchicine is usually done to relieve the pain associated with the gout. So if this colchicine or NSAID is not able to control, or if these drugs are contraindicated, then only corticosteroids are used. So in all the cases of this arthritis, whether it is rheumatoid arthritis, osteoarthritis, rheumatic fever, or the gout, the pain is usually cured, the pain is usually treated with the use of NSAIDs. So as said earlier, if NSAID is not able to control, or there is contraindication of NSAIDs, then only corticosteroids are used. Similarly, so continuing with the uses, indications of corticosteroids, these corticosteroids are used in different collagen disease, which is form of the connective tissue disorder, and different autoimmune diseases like systemic lupus erythematosus, so myasthenia gravis, rheumatoid arthritis, because it has got the immunosuppressant activity, and autoimmune disease are usually occurs as a result of formation of autoantibodies, which directs the normal cells of the body. So since it has got the immunosuppressant activity, they are used in different autoimmune diseases. Similarly, in organ transplantation, so to reduce the inflammatory, to reduce the this immunity, increased immunity that is associated with the recipient. So these are being used in the organ transplantation. They're also used in different allergic reactions. So they are mainly used for the treatment of anaphylactic shock, so or the anaphylaxis, which is the severe form of hypersensitivity reaction, and they can be also used in different forms of allergic reactions like angioedema or the urticaria. So they are also used in different forms of allergy like angioedema, which is in which there is a swelling of the lips, swelling around the eyeballs, and urticaria, which is the form of races. And the main use of these corticosteroids is in anaphylactic shock, and for the anaphylactic shock to be treated, the drug of choice is always the adrenaline. So subcutaneous or intramuscular adrenaline is given in case of anaphylactic shock or anaphylaxis, whereas these corticosteroids, when used for the anaphylaxis, for the treatment of anaphylaxis, it takes longer time to act, and it's not the substitute for the adrenaline, which acts immediately in anaphylactic shock. They are also used in different lung diseases. They are used in bronchial asthma. So in the bronchial asthma, they are mainly used as prophylactic therapy. And for these, inhalation preparation are used like inhalation budesonide, inhalation beclomethasone, etc. And they are also used in acute asthma exacerbation, which is known as the status asthmaticus. And in case of status asthmaticus or acute asthma exacerbation, so usually IV hydrocortisone are used. And for the treatment of severe chronic asthma, usually glucocorticoid like oral prednisolone are being used. So in bronchial asthma, all the forms of the all the preparation of corticosteroids like use like oral prednisolone, similarly inhalation beclomethasone, budesonide, and similarly IV hydrocortisone. And they are also used for long maturation if preterm baby is born. The use of glucocorticoids, so corticosteroids, especially the glucocorticoid in different infective disease is a bit controversial. So it is not used in simple infective diseases because in infection it decreases the immune response. So it is only indicated in serious forms of infections to tide over crisis or to prevent complications that is associated with different serious infective diseases, different infections. And so they are only used in serious forms of infections like severe forms of tuberculosis. The tuberculosis has transmitted to different parts of the body like brain. So they are also used in severe lepra reaction, and they are also used in certain forms of bacterial meningitis. They are used in different forms of eye diseases, and they reduces the inflammation associated with the ocular diseases and hence may prevent blindness. They are used in allergic conjunctivitis, which affect the conjunctiva, iritis, so which affect the iris, retinitis, which affect the retina, and optic neuritis, which affect the optic nerve. Similarly, they are effective in the eczema, different skin diseases like eczema, which is red and itchy skin. Similarly, pemphigus vulgaris, which in which there is the formation of painful blisters in the skin and mucous membrane, and it is also the autoimmune diseases. And it is used in skin diseases like Stevens-Johnson syndrome. So this is the picture showing Stevens-Johnson syndrome, which is a serious disorder of the skin as well as the mucous membrane. And there is painful rash as well as the formation of blisters similar to that of the pemphigus vulgaris. But this blisters eventually peels off, and it is a very serious condition and need to be treated as early as possible. Similarly, it is also used in the treatment of, not in the treatment of neurocystic sarcosis, because for the treatment of neurocystic sarcosis, usually albendazole or praziquantel are used. And this neurocystic sarcosis, so usually steroid therapy or the corticosteroid therapy is usually given to inhibit the inflammatory reaction. So that occurs as a result of dying larva. So the main treatment of neurocystic sarcosis, which is caused by the pork tapeworm, which occur in which there is infection around the CNS. So the main treatment is the use of albendazole or the praziquantel. So it kills the cyst that is present on the CNS, but this steroid therapy, corticosteroid therapy, is necessary to inhibit the inflammatory reaction that occurs as a result of dying larva due to the albendazole or the praziquantel. They are used in different malignancies, as for example, in the lymphatic leukemia or lymphomas. So they have the lympholytic activity. So they are used in lymphatic leukemia as well as lymphoma. And they are also used to test pituitary adrenal axis function. So whether the hypersecretion or the hyposecretion of adrenal hormones is either due to the adrenal gland or it is due to the pituitary gland. So to test that, usually high doses of dexamethasone, which is very potent glucocorticoid, so they are given to test the pituitary adrenal axis function. So coming to the adverse effect of these corticosteroids, so mineralocorticoid activity, so they causes the salt and water retention, and the salt and water retention can lead to edema, and this can lead to hypertension, rise in BP, and this causes the loss of potassium from the body, loss of H plus ion from the body, leading to hypokalemia as well as the alkalosis. So mineralocorticoid activity is usually limited to the adverse effect of mineralocorticoid activity is mainly limited to the sodium and water retention, which can lead to edema, so hypertension, hypokalemia, and alkalosis. And this is the reason they are contraindicated in the patients who are suffering from the edema or suffering from the congestive heart failure, which who are suffering from the hypertension as well. Coming to glucocorticoid adverse effects, so Cushing habitus. So there is a characteristic appearance with a rounded face, buffalo hump, and obesity of the trunk, and relatively thin limbs. So this glucocorticoid has the limb. They have the lipolytic activity, so it causes the lipolysis, especially from the extremities of the body, like the limbs, causing the thin limbs. Whereas this lipolysis product, so they get deposited on the central portion of the body, so with the rounded face, buffalo hump, and truncal obesity. The skin becomes fragile, so there is a thinning of the skin becomes fragile, there is easy bruising, and there is hirsutism, since these corticosteroids have also the glucocorticoid, mineralocorticoid, both they have also some amount of the sex androgens, so it increases the hair, so it can lead to the it increases the hair growth, so it can lead to the hirsutism. Similarly, so it can cause hyperglycemia, glycosuria, and precipitation of the diabetes. So it decreases the glucose uptake by the cells, so it leads to the hyperglycemia, and it leads to the glycosuria as well. So presence of glucose in the urine, and there occurs the precipitation of the diabetes, and this is the reason they are contraindicated in patients who are suffering from the diabetes mellitus. So there can be muscle weakness, there can be myopathy, and this muscle weakness and myopathy usually occurs as a result of loss of potassium from the body, so which can result in muscle weakness, myopathy. And since it causes the suppression of the immune response, so there is susceptibility to the infections who are taking these steroids, corticosteroids, and since they also cause they cause the suppression of the immune system, so there is delayed healing of the wounds, and they causes the reduction, they causes the inhibition of the prostaglandin synthesis, so there is chances of peptic ulceration, and this is the reason they are also contraindicated in the patients who are suffering from the gastritis or the peptic ulcer. Similarly, so they are contraindicated, as well as the adverse effect of this corticosteroid is the osteoporosis. So they increases the number of osteoclasts, they decreases the number of osteoblasts, so osteoporosis can be there, and it causes the growth retardation in the growing children, and hence this is the reason, so they are contraindicated in growing children, and they will have also tendency to cause the cataract and glaucoma when given in pregnant women, so it can cause the fetal abnormalities by crossing the placenta, and hence they are also contraindicated in the pregnant women as well as the nursing mothers. And the high doses of these drugs, glucocorticoid, can lead to mania, so euphoria, so they can cause psychiatric disturbances, as well as they are contraindicated in the patients who are suffering from mania or psychiatric patients. So when this glucocorticoid, mineralocorticoid, or the corticosteroid is given as therapy, so when exogenous therapy of this glucocorticoid are being given, or mineralocorticoid or corticosteroid is being given, so it decreases the endogenous production of the glucocorticoid or mineralocorticoid. So it causes the suppression of hypothalamo-pituitary adrenal axis. So the list of this adverse effect of corticosteroids is very long, And due to the adverse effect that is caused by the use of these corticosteroids, the use of corticosteroids in any of the pathological conditions should be cautious. And if a patient who are on the corticosteroid therapy develops an infection, so steroids should not be discontinued despite its propensity to weaken the host defense and delay healing. So rather, the dose may have to be increased to meet the stress of the infection. So patients who are on the corticosteroid therapy and they develop the infection in between, so corticosteroids should not be discontinued. So although it has the chances of causing the weakening of host defense as well as they have the chances of delaying the wound healing, so it should not be discontinued. But the dose of these corticosteroids should be increased to meet the stress of infection. So contraindications, as said earlier, so it is similar to that of the adverse effects. So peptic ulcer is there. So in peptic ulcer, these drugs should not be used because it decreases the pH synthesis and there is more aggravation of the peptic ulcer. Similarly, so diabetes, it decreases the glucose uptake by the, it inhibits this glucocorticoids, inhibits the glucose uptake by the peripheral cells. There is chances of increasing the glucose level in the blood, in the plasma. So diabetes can be exaggerated, can be aggravated. So and hence this should be contraindicated in the diabetic patients. Similar with the hypertension, it causes the sodium and water retention. So it should not be used in the hypertensive patient because this can aggravate hypertension. Similarly, the patient with osteoporosis, it increases the number of osteoclasts, it decreases the number of the osteoblasts, which are the bone forming cells. So should not be used in the patients who are suffering from the osteoporosis. And this should not be used in simple infections, and this should not be used in infections such as tuberculosis or the other infections. So the use of corticosteroids in the treatment of infection, so it should be used only in the severe forms of infection. And they should not be used in psychosis because they have the tendency to cause mania, they have the tendency to cause euphoria, and they, since they decreases the seizures threshold, so they should not be used. They are contraindicated in the epileptic patients, patients which are suffering from the seizures. Similarly, it causes the sodium salt retention, so it can aggravate the congestive heart failure in which there is already the sodium and water retention, there is already the edema in the body, and they are excreted via the kidney, so they should not be used in patients who have the renal failure. So whenever a patient is taking corticosteroid, so there are some general measures. As for example, a single dose, even excessive, is not harmful, can be used to tide over crisis, even when benefit is not certain. So when you are given corticosteroid, so as for example, you are giving the corticosteroid for a day, and you are giving the corticosteroid for a month or for a week. So, which is more harmful? So, the person who is getting the corticosteroid for a longer period of time, as for example, if the person is getting corticosteroid for a week or a month, so that is more harmful. So, and if the patient is taking the corticosteroid for a day, so even in a higher dose, that is not so much harmful. So, a single dose, even excessive, is not harmful and can be used to tide over crisis, to meet an infection when the benefit is also not certain. Similarly, short course, so as said earlier, even high dose are not likely to be harmful in the absence of contraindications. And long-term use is potentially hazardous. So if you're giving the corticosteroid for a long period of time, for a month, for a year, which is very hazardous, and duration of treatment should be short, as well as the dose should be kept to minimum. So when a patient is taking corticosteroid, initial dose depends on severity of the disease. So start with high dose in case of severe illness and reduce gradually after symptoms subside. And while in mild cases, so the dose should be started with the lowest and titrate upward. So in case of severe infections, so the dose can be increased initially, which can be decreased afterwards gradually. Whereas in case of mild infection, so dose should be lowest dose and which can be increased later on. And if the patient is getting corticosteroid, for a long period of time. So if possible, so alternate day therapy can be given. As for example, a patient is taking corticosteroid for Sunday, so stop corticosteroid on Monday and you can resume on the Tuesday and so on. So switch to alternate therapy if possible. It is again to reduce the adverse effect that is associated with the long-term use of corticosteroids. So use shorter acting steroids like hydrocortisone, so prednisolone, which are short acting. So hydrocortisone is very short acting corticosteroid, whereas prednisolone is intermediate acting. So whenever possible, use shorter acting corticosteroid as lowest possible dose and for shortest period of time. And when you are using corticosteroid, so especially for longer period of time, so there should not be sudden withdrawal, there should not be abrupt withdrawal. So it is so no abrupt withdrawal, no sudden withdrawal should be done after a corticosteroid has been given to a patient for more than 2 to 3 weeks. It may precipitate severe or acute adrenal insufficiency. As for example, when a patient is receiving corticosteroid for a long period of time, especially after for 2 weeks or for 3 weeks or longer than that, so the patient is getting exogenous corticosteroid, or patient is getting the supplement corticosteroid from outside. So what happens? So now the body starts to, now the adrenal gland so it stops to produce the corticosteroid. So endogenous production of the corticosteroid will be ceased, will be suppressed. So when a patient is getting corticosteroid for more than 2 to 3 weeks, so no abrupt withdrawal should be there, because when you abruptly or suddenly stop the exogenous corticosteroid, so and there is also the sudden stoppage of the endogenous corticosteroid production from the body. So there is stoppage of both exogenous as well as the endogenous corticosteroid. So there will be the acute adrenal insufficiency. So if a patient is getting corticosteroid for more than 2 to 3 weeks, so always there should not be the abrupt withdrawal, there should not be sudden withdrawal. Infection, if there is infection, if there is severe trauma, if there is surgery or any stress during corticosteroid therapy, so increase the dose. So it is in order to reduce or suppress the complications that occurs with the infection, trauma, or the surgery. And whenever possible, so use local therapy. So don't use systemic therapy of corticosteroid if possible. As for example, topical corticosteroid in the form of the cream, lotion, ointment in the cutaneous preparation. Similarly, in case of asthma, so inhalation corticosteroids rather than use of systemic corticosteroid like hydrocortisone or prednisolone. So intranasal corticosteroids should be done whenever possible. So this finishes the corticosteroid, and there are some MCQs related to the corticosteroid. So answer these. So select the regimen of corticosteroids which has maximum adverse effect potential. So option number 1, prednisolone, that is used for 20 mg per day oral for 1 year. Prednisolone 60 mg per day for 7 days. Dexamethasone 4 mg IV daily for 3 days, or methylprednisolone 1000 mg IV twice per day for 5 days. So which of the corticosteroid, which of the regimen of the corticosteroid has maximum tendency of causing adverse effect? Any other answer? So the answer is A, because corticosteroid, when given for very long term, so it has the highest risk of causing adverse effect profile. So the dose doesn't matter. So it is the dose doesn't matter much. So it is the duration of the corticosteroid therapy. So which has more risk of causing the adverse effect profile. So prednisolone, that is used for 20 mg per day oral. So 1 year has the maximum tendency of causing the maximum adverse effect. So continuing with the MCQ, a patient has been diagnosed to have bronchial asthma and is maintained on oral prednisolone and salbutamol So prednisolone is corticosteroid, and salbutamol is the beta-2 agonist, which is the bronchodilator, so which you have already read in your respiratory section. And so he develops chest infection while being treated for the bronchial asthma. And which of the following measures would you like to take? So option number 1 is stop prednisolone, reduce prednisolone dose, increase prednisolone dose, substitute prednisolone with inhaled budesonide. So the answer is increase the dose of prednisolone. So in case of any stress, in case of infection, in case of trauma, so when the patient is under the corticosteroid therapy, the dose need to be increased to meet over the crisis to reduce the complications. So hyperaldosteronism causes all except hypernatremia, hypokalemia, hypertension, metabolic acidosis. So which of the following is caused by increased amount of aldosterone except? Any other answer? So the answer is metabolic acidosis, because increased amount of aldosterone will cause sodium and water retention, will lead to the hypernatremia. So similarly, it will cause the excretion of the potassium, will cause the hypokalemia. Increased sodium and water retention will lead to the hypertension. So whereas increased amount of aldosterone will lead to the loss of H plus ion. So alkalosis will be there. So nor the metabolic acidosis. So the answer is the D. At same concentration of steroid or corticosteroid, which is the most potent preparation? So ointment, cream, or the lotion? So we are at the same concentration of the corticosteroid, because corticosteroids are also available in the topical preparation in the form of the ointment, cream, or the lotion. So which of the following has the most potent is the most potent preparation? So ointment, cream, lotion. Any other answer? So all these forms of topical preparation of steroid, so they are used in different, mostly they are used in different skin diseases, or they are also used in eye diseases in the form of the eye drop, in the form of the ointment, etc. So ointment is the form of preparation, is topical preparation which has got the 80% of the oil and 20% of the water, whereas cream has 50% of the water and 50% of the oil, whereas the lotion has the 20% of the oil and 80% of the water. So above all this, among all this preparation, ointment is the most potent one. All of the following are correct regarding steroids, except they inhibit the release of arachidonic acid through action on phospholipase A2, binds to plasma membrane receptor on, and follows internalization, influence nuclear changes, increases glycogen synthesis in the liver, accelerates osteoporosis. So which of the following is false? Following statement is false. Any other answer? So the answer is B. So all the other statements are true. So they inhibit the release of arachidonic acid through action on the phospholipase A2, and inhibit the production of both cyclooxygenase as well as the lipoxygenase enzymes and causes the anti-inflammatory action. It also increases the glycogen synthesis in the liver, and they also causes the osteoporosis. Whereas coming to the mechanism of action of these corticosteroids, so they act via the intracellular receptors or the nuclear receptors. So this statement B is false. So they don't bind to plasma membrane. So the answer is B. A patient has been diagnosed to have brain tumor. You would prefer to give her betamethasone, dexamethasone over hydrocortisone. So all are the steroids, corticosteroids preparation as a steroid to decrease our cerebral edema because they are more potent. They do not cause salt and water retention. They can be administered intravenously. They inhibit brain tumors. So which of the statement is true? So this betamethasone, dexamethasone are very potent glucocorticoid. They don't have mineralocorticoid activity, and hence they don't cause salt and water retention, and so decrease or cerebral edema. So in brain tumor, so you want the patient to have the salt and water retention. So therefore, you need to select the very selective glucocorticoids. So for that, you are giving betamethasone and dexamethasone. The answer B is correct. So because they do not cause salt and water retention, they are preferred over hydrocortisone. And this finishes the corticosteroids. So any question? CR यो के अरे एटेन्डेन्स चाहिँ मेन्टेन गर्दै गर्नु है. Any question? बुझेन. स्लाइड को PDF हुन्छ. म सबै इन्डोक्राइन सकेपछि एकैचोटि गर्छु है. If not, so I'll stop here for today. Thank you.